approach abnormal liver enzymes. Approach abnormal liver enzymes. We're going to start, and it's an MCC objective. So the objective states this: abnormal liver function tests are common in clinical practice. Appropriate investigation can distinguish benign reversible liver disease from potentially life-threatening conditions. Then it goes on to say this: causal conditions include hepatocellular conditions like acute conditions. So, for example, infections, so like hepatitis and all those things. Then it goes on to say medication. Then it goes on to say chronic conditions like infections, medication again. Then cholestatic, that is, things which have to do with the gallbladder. Intrahepatic, that's pregnancy related, and hepatic, that is gallstones. And I've intentionally hinted on the gallstones because I'll be focusing today's class on that. Now, there can also be congenital abnormalities like Gilbert's disease and other conditions which can cause abnormal liver enzymes like celiac disease. Then you go on, every objective has a key objective, and it states this: given a patient with abnormal liver function tests, the candidate will diagnose the cause, the severity, and complications, and will initiate an appropriate management plan, in particular, assessing for potential underlying liver disorders or systemic diseases. So you realize that today's class, as we go through it, we'll be dealing with some of these things. How will I know that there's a systemic presentation for the patient's condition? Then the enabling objective: given a patient with abnormal liver function test, the candidate will list and interpret critical clinical findings, including differentiate between abnormal liver function tests due to disease that require treatment from those that do not. For example, a condition like Gilbert's disease, Gilbert syndrome. All of us know that we don't need to manage that patient. We just need to, we don't need to give any medication. We just need to observe and make sure the patient's condition is not deteriorating. And then differentiate primary hepatic disease from systemic disease. We've done all this in that previous class. If you want to find it, you can let me know after the class. I will tag it in the Facebook group so that you can, be able to review it. And then identify complications related to the presence of liver disease, like bleeding, like ascites. And then another enabling objective: list and interpret critical investigations, including laboratory tests, which are appropriate for the identification of specific acute and chronic liver diseases. And then diagnosis, imaging, ultrasound. Okay. Then I go on: construct an effective initial management plan, including determining if the patient requires urgent referral or hospitalization, and referring the patient for specialized care, like non-urgent if necessary, and counseling and educating the patient to prevent further hepatic insult. For example, primary and secondary prevention strategies for viral hepatitis, communicating with the public health authorities if applicable. All these have been dealt with in your MedCognito portal. But today, I want us to focus on the cholestatic part of things, because it was talking about gallbladder disease as well. When you deal with a condition like acute cholecystitis, how do you navigate it such that you can be able to ace the exam? So we are diving right into it. And as I said, today, we're going to intersperse every major chapter or every major topic with questions. So you deal with a question and then we do a teaching point. So I need someone to help me, a volunteer, to quickly start reading this question. Dr. Kano, let's go. Let's go.
A 45-year-old woman presents to the emergency department with severe right upper quadrant pain, fever, and leukocytosis. An ultrasound reveals gallstones and a thickened gallbladder. What is the most likely diagnosis?
Beautiful. So please kindly type in your answer. Is it A? Is it B? Is it C? Is it D? And you have to make sure that you are solving this question within 1 minute. Within 1 minute. Is it A? Is it B? It looks like there's a consensus. Everybody is going for B, B, B. Acute cholecystitis. So acute cholecystitis is the answer. And the reason is very simple. The patient presents with symptoms typical of acute cholecystitis. And you may ask, why am I saying that? Including right upper quadrant pain, fever, and leukocytosis. The presence of gallstones and a thickened gallbladder wall on ultrasound further supports this diagnosis. So even this teaching point alone helps us to know how to pick up a case of acute cholecystitis in an exam setting. Right upper quadrant pain, fever, leukocytosis, presence of a gallstone, and thickened gallbladder wall. Down the line, you realize that not every cholecystitis will present to the patient with a gallstone, and you will come to understand that. Now, while we are dealing with this teaching point, I also want to introduce the concept of chronic cholecystitis. It typically presents with less severe symptoms and is often associated with a history of recurrent gallbladder attacks. So when you see a patient who is presenting with when your examiner introduces the word recurrent gallbladder attacks, be very careful. That is not acute, that is chronic. Acalculous cholecystitis, so that is the kind of cholecystitis where there is no stone. While it can cause similar symptoms, accounts for smaller percentage of cases and usually occurs in critically ill patients. And down the line, you will realize that there is a particular organism which the objective wants you to know, which causes acalculous cholecystitis. Okay, gallbladder dyskinesia is a functional disorder and does not typically present with fever and leukocytosis. So why did we choose acute cholecystitis and not acalculous cholecystitis or gallbladder dyskinesia? Look, acalculous cholecystitis was ruled out because the question stated that the patient has gallstones. Gallbladder dyskinesia was ruled out because the question stated that the patient has leukocytosis and fever. Gallbladder dyskinesia does not present with fever and leukocytosis. So, doctors, this is the first trick we are using. Another question. Who wants to try this as well? Dr. Ronnie, let's go.
Yeah. A patient with recurrent right open quadrant pain is diagnosed with functional gallbladder disorder. Which term is more appropriate to describe this condition?
Beautiful.
Option A, chronic cholecystitis, acute cholecystitis, gallbladder dyskinesia, and acalculous cholecystitis. I'll go for chronic cholecystitis because
of the word recurrent.
Recurrent, yeah.
But look at this. Okay,
right open quadrant pain.
Okay, and then functional disorder. Will anyone go for something different? So I see A and C are battling. A and C are battling.
yeah.
A and C are battling.
Gallbladder dyskinesia. C, option C.
A and C are battling. Beautiful. So Dr. Ronnie saw his mistake and changed his mind quickly. And we are going for gallbladder dyskinesia because functional gallbladder disorder is also known as gallbladder dyskinesia, and it refers to pain which is caused by gallbladder motility issues, because the gallbladder has to squeeze and get a bile out, squeeze and get a bile out, squeeze and get a bile out, right? This condition is different from chronic cholecystitis. So what we do at MedCognito is, even when you are dealing with a question, we also use the question as a teaching point. And that is what you see in the mocks that are in your portal right now. You realize that every explanation, every question comes with an explanation, and then the explanation is a teaching point as well. Okay, so this condition is different from chronic cholecystitis, which involves chronic inflammation and is typically associated with gallstones. Acute cholecystitis involves acute inflammation, usually due to gallstones. And if the patient had acute cholecystitis, you might have been told the patient has a fever, the patient has leukocytosis, but this one did not say anything like that. Beautiful. So now, cholecystitis, what's the teaching point here? This one, I want you to write it down, take a screenshot of my beautiful face, just make sure they get it so that in the exam, you don't miss it. Any patient with right upper quadrant pain plus fever plus leukocytosis plus gallbladder inflammation for the MCCQE1 exam, that patient has cholecystitis, acute cholecystitis. What are the things which will be presented to me in a question stem so that I can say this is acute cholecystitis, right upper quadrant pain, fever, leukocytosis, gallbladder inflammation. Now, what is the other teaching point about acute cholecystitis? Majority of acute cholecystitis is caused by gallstones. Majority. It is only minority which is caused by acalculous cholecystitis. And I said it again. Acalculous cholecystitis basically is cholecystitis without a gallstone. Cholecystitis without a gallstone. Now, what about chronic cholecystitis? Because Dr. Ronnie read about it. He read the case for us. Chronic inflammatory cell infiltration of the gallbladder almost always has a gallstone present. So with chronic cholecystitis, there's almost always a gallstone which is present. It can result from recurrent attacks of acute cholecystitis. Recurrent attacks of acute cholecystitis. Now, what are the complications of chronic cholecystitis? So that's also something we need to know. Write this down in your book. Chronic cholecystitis can lead to gallbladder fibrosis. It can also lead to gallbladder thickening, gallbladder fibrosis, gallbladder thickening.